Hello, everyone. I'd like to welcome you to today's webinar titled Taking the Difficulty Out of C. Diff. Today's presenter is Dr. Todd LePine, and to give you some background information, Dr. LePine graduated from Dartmouth Medical School and is board certified in internal medicine and certified through the Institute of Functional Medicine. Dr. LePine is a staff physician with Dr. Mark Hyman at the Ultra Wellness Center located in Lenox, Massachusetts in the Berkshires. Prior to joining the Ultra Wellness Center, Dr. LePine worked as a staff physician at Canyon Ranch Health Spa in Lenox, Massachusetts, consulting with patients from around the world looking for optimal health. He is a faculty member of the American Academy of Anti-Aging Medicine and the Institute for Metabolic Medicine. The focus of his practice is to help patients achieve optimal health by restoring balance to nutritional biochemistry in the body and to teach patients how to adopt healthy lifestyle habits. His areas of interest within the medicine include optimal aging, biodetoxification, exploration of the human microbiome and its effect in both health and disease, autoimmune disorders, and the neurobiology of mood and cognitive disorders. And Dr. Todd, thank you for being with us today. We've had a great deal of interest in this topic, and we're excited to have you do this presentation for us.
Okay, great. Well, thanks a lot, Jeff, for that introduction. And I want to welcome everybody on this Friday. I'm up in the Berkshires, and Berkshires are actually known to be fairly cool. That's why a lot of people from Boston and New York prior to air conditioning would come up here. So I'm sure it's probably hot for everyone else out there. And I appreciate everybody taking the time out on their lunch hour to attend this. For those who signed up and aren't able to attend, this will be recorded and it'll be available for later reviewing. So I think that this topic, which I'm going to talk about for the next 45 to 60 minutes, is an interesting topic. It's very clinically relevant, which is the clinical situation of Clostridium difficile. And this is an area that is very common in the clinical practices, especially seen in inpatient populations, especially ICU, CCU patients, but it can also be seen on the outpatient. It can also be seen in nursing home situations, also in dentist office with prophylaxis with antibiotics for dental procedures, etc. So we'll go ahead and get started here. And this is a nice paper looking at the overview of, oops, let me move that down here just a second here. Let me get back there. Okay, so this paper is looking at the overview of clostridial toxins. Now remember, Clostridia is a class of bacteria, and there's a lot of different types of clostridial organisms, and Clostridia produce the highest number of toxins of any type of bacteria, and it can be involved in a variety of different very severe diseases in both humans and animals. Most of the clostridial toxins are pore-forming toxins that are responsible for gangrene and gastrointestinal diseases, and there are more than 200 different clostridial species. 15 produce very potent toxins. And pathogenic Clostridia are not invasive bacteria, interestingly, but they secrete these molecules or active molecules that act at a distance from the bacteria and cause all types of different symptoms and lesions in these clostridial diseases. Now, some of the ones that I'll be talking about just as an overview are Clostridium perfringens. This is the type of bacteria that produces foodborne or gas gangrene. This can be seen both in animals and humans. The one that we'll be talking about more today is Clostridium difficile. And then there's also Clostridium botulinum, which we know about botulism. So there are other different types of organisms in the Clostridial family that produce a variety of different GI diseases or intestinal foodborne diseases. And the way that they group the Clostridial toxins is that there are 3 different types of toxins, and this is a little bit on the science side. It's not as much clinically relevant, but I just want to mention this. So there are the large clostridial glycosylating toxins, and then there are the binary toxins. Both of these together alter the actin cytoskeleton. and modify the actin monomers. And this in turn is associated with what we term increased intestinal permeability or leaky gut, which you definitely will see in Clostridium difficile infections. And then there are the neurotoxins. The Clostridial neurotoxins have proteolysis as key components to these exocytosis. Botulinum neurotoxins inhibit the neurotransmission at the neuromuscular junction. And then there's the tetanus toxin, which inhibits the interneurons of the CNS. So again, there's a variety of different mechanisms by which these toxins take place. And the one toxin that we all know of is Botox. This is an interesting clinical use. People use Botox for a variety of different purposes. It first came out to help with sort of cosmetics, more or less paralyzing facial muscles and alleviating wrinkles. But this has also been used as adjunct in a variety of other medical conditions, including migraine headaches and sometimes other spastic disorders. And I mention this because the toxin that is produced by Clostridium botulinum is very, very toxic. And this ongoing discussion of the various types of toxins just show you how toxic it is. Type H toxin, which is one of the 8 types of botulinum toxin, is considered the deadliest substance in the world. An injection of only 2 billionths of a gram or 2 nanograms can cause death in an adult. So this is to really highlight how very, very small quantities of these clostridial toxins can have a huge sort of cascading effect in the body. And that's one of the reasons why C. diff, even at low levels, can manifest in such clinical difficult cases. I think the next slide is talking about the role of toxins in C. diff. And again, specifically in C. diff, there's the type A toxin, type B toxin, and there's also a type C toxin. That's not necessarily measured clinically, but these toxins act on colonic epithelium and the immune cells and induce a sort of a cascading complex of cellular events that result in fluid secretion, inflammation in the GI tract, tissue damage, and these are all hallmarks of Clostridium difficile infections. Another name for C. diff is pseudomembranous colitis, which is sort of what it appears on colonoscopy. This is a video slide just sort of to highlight the effect of what we call small effects or a cascading effect. Hopefully the audio will work on this, but I thought is a good example to demonstrate, and I'll just go ahead and let this play.
The smallest domino is about 5 millimeters high and 1 millimeter thick, and I will carefully place it. And there are 13 dominoes. And the largest domino, it weighs about 100 pounds and is more than a meter tall. Ready? Boom.
So that's really showing how very, very small initial compounds can have a cascading effect. And that's basically what happens in C. diff. You have very, very low levels of these toxins. Again, C. diff toxin A and toxin B from a clinical standpoint can have this cascading effect in the body and can cause a very, very significant inflammatory component and clinical presentation of prolonged protracted diarrhea. And this slide sort of nicely illustrates all of the different components to it, where you get the input of prostaglandins, cytokines, interleukins, recruitment of neutrophils, and ultimately this presents as the clinical Clostridium difficile infections. And I'll digress a little bit here. This is a book, some of you may have read this, by Anna Karenina, by Leo Tolstoy. And the premise of this book is understanding how families work. And we've all heard the term dysbiosis, and the definition of dysbiosis is an imbalance of gut bacteria. Orthobiosis is considered the healthy balance of the bacteria, and it's really a question of how do we define what is a normal orthobiotic colonic microbiome, and what is the definition of a dysbiotic microbiome. And this next paper sort of helps us to better understand how we can sort of conceptually wrap our minds around what is dysbiosis. And this is using the Anna Karenina principle to animal microbiomes. In this particular paper, they talk about the stress and stability of the microbiome, and they consider a complementary alternative that the microbiological changes induced by many perturbations are stochastic, and therefore lead to transitions from stable to unstable community states. And they talk about the Anna Karenina principle of the animal microbiomes, in which dysbiotic individuals vary more in microbial community composition than healthy individuals. And this is a quotation from Anna Karenina, which is the dictum that all happy families look alike, and all unhappy families are unhappy in its own way, which is to say that there are many different ways in which you can have dysbiosis in the GI tract, and it can manifest for a variety of different reasons. So here we have a cartoon from that same paper looking at various environmental impacts that can cause a altered microbiome. You can have retroviral infections. You can have environmental stressors such as tobacco. You can have chemically mediated input, and then also secondary bacterial infections. And that takes the microbiome from a complex, stable standpoint into a microbiome that is altered and unstable, or what we call dysbiotic. The other thing that is also interesting, and I call this the unifying field theory of medicine, is that an imbalance of the microbiome is associated with pretty much almost every health condition that you will see. So difficulties in brain and behavior, things such as depression, anxiety, autism have been linked to imbalances of the gut-brain axis. Asthma and allergies have also been associated with imbalances of the gut microbiome. Hypertension, cardiovascular disease, colon cancer, the obesity, which is, I think, one of the biggest things that we're seeing on a clinical basis every day, and metabolic syndrome, and other things, especially inflammatory bowel disease. And these are all different types of clinical conditions which are associated with their own unique imbalance of the microbiome, or what we call unique dysbiosis. So this is a nice summary slide looking at populations that are at increased risk for C. diff, people who are on prolonged proton pump inhibitors, valacyclovir use, obviously the use of antibiotics, other patients, advanced age, patients with post-gastrointestinal surgery, inflammatory bowel disease, people who have prolonged stay in healthcare settings. So these are, again, nursing home type factors. And then also patients who have underlying immune problems with low albumin and low levels of production of antitoxin and B antibodies. As far as the diagnosis of, or laboratory diagnosis, there are a variety of different ways, including enzyme immunoassay, real-time PCR, cell culture, anaerobic culture for toxigenic C. diff strains, and also you can do assays for the toxins itself. I'll actually talk about that because the GI map test is not actually checked for the toxins, but it checks for the bacteria which produce the toxins. As you can see here, the real-time PCR has specificity of about 97% and sensitivity of about 93%. So this shows you sort of the pathway of developing clinical manifestations of Clostridium difficile. You have spores, which can cause a cross-contamination. Again, you can get these in the GI tract via living in extended care facilities or hospitals. Disruption of the barrier affect the germination of the spores. I'll talk about that a little bit later as it relates to the concept of quorum sensing, and then colonization, and then toxin production. Now remember, a lot of us are walking around with Clostridium difficile A and B in us, and we're asymptomatic. It's only when the bacteria produces toxins that you develop the clinical manifestations of C. difficile colitis. Now, important concept to understand is the development of biofilms. Now, biofilms are found on any mucosal surface in the body. There's oral microbiome biofilms, and there's gut biofilms. And it's not so much that biofilms are good or bad, it's just that biofilms are where bacteria live, and they don't live as individual organisms, they live in a community, and there's a whole variety of different organisms that live within biofilms. And oftentimes biofilm development can be one of the reasons that infections are so difficult to eradicate, because it's hard for antibiotics to penetrate biofilms. An example of this is patients who are colonized with Pseudomonas aeruginosa, and that is one of the more difficult biofilms to get through. This is an electron microscope of the biofilm formation in Klebsiella pneumoniae. And it's thought that within these biofilms, there's a phenomenon which is known as quorum sensing. For those of you who are familiar with this, I find this a fascinating conceptual concept. We don't have a good way clinically right now to identify quorum sensing, but in the laboratory, we know that it exists. Likewise, we don't have a good way of testing or, in fact, necessarily treating biofilm formation. But to understand that this is taking place in the body, it helps you to better sort of wrap your mind around what's happening in patients who develop these more advanced C. difficile colitis infections. So quorum sensing is where bacteria actually talk or communicate to each other. They use various chemicals for that. Also realize that when there's quorum sensing, bacteria are acting as a multicellular organism. And bacteria can also distinguish self from others through quorum sensing. And the possible role of quorum sensing in dysbiosis. And this is actually an interesting concept, that when the bacterial levels reach a certain level, that's where the bacteria start having different types of properties in the more complex organization. So this is where, from a cartoon standpoint, you have a microbial community, and each of the bacteria are communicating at some level. Again, they're not talking to each other in the sense that we talk, but they have signaling molecules. And the behaviors here is that you have symbiosis, where the bacteria sort of live off of each other. There are virulence factors, there's competition for nutrients, there's conjugation. They can actually produce antibiotics. They also can have different motility properties. They can produce spores, which is what C. diff will do. And there can also be biofilm formation when you have this group type behavior in the GI tract. And this particular paper talks about the language of hormones in what's called the bacterial host communication. So given that eukaryotic cell-to-cell signaling typically occurs through hormones, bacterial cell-to-cell signaling occurs through quorum sensing. In this paper, they speculate that quorum sensing might be a language by which bacteria and host cells communicate to one another. This is just a little bit of a historical thing. This is a vase that was found in forget exactly where it was, but it was found, and it's got Proteus on it. Now we know Proteus as an organism, Proteus mirabilis, and the reason why Proteus is actually called Proteus is that it can have many forms. So in the Greek mythology, Proteus took on many types of appearances, and Proteus mirabilis as a bacteria, which also can cause a variety of different diseases, has been associated with autoimmune diseases, is capable of taking on various forms. And this is important, again, conceptually to understand what happens with Clostridium difficile when it reaches critical levels and can act in different ways. So this particular paper shows that Proteus mirabilis is capable of swarming, and it can form a multicellular behavior in which bacteria differentiate from the short rod type members of the family, Enterobacteria acei, termed the swimmer cell, into a hyperflagellated, elongated bacteria capable of rapid and coordinated population migration across surfaces, and this is called the swarmer cell. So this is what Proteus looks like when you just have a couple of them, and you can see all of the little villi that stick out. And what you can also have in under various conditions is you take a consolidated cell, it differentiates, and then they start attaching to one another, and you develop this sort of swarming organism, which is a multicellular raft organism. And this is again a thing that happens in bacteria. And again, different types of bacteria will have this effect in the body, and Proteus being one of the more prototypical ones for this. And again, this happens through the effect of quorum sensing, where it senses how many other types of organisms are around it and whether or not it's going to be competed against. Now, I mention all of this because this next paper talks about how toxin synthesis of Clostridium difficile is regulated through quorum signaling. Again, this is more in the laboratory, but I think it's important for us to understand this so that we can better understand our patients who have C. diff and why do they develop it. So Clostridium difficile infections is the most common definable cause of hospital-acquired and antibiotic-associated diarrhea. In the US, it costs between $1 and $4.8 billion annually. And in this particular paper, they report that C. diff regulates its toxin synthesis by quorum signaling, in which novel signaling peptides activates transcription of the disease-causing toxin genes. So I found this really quite fascinating. And going further in this particular paper, quorum signaling molecules accumulate in the environment as the bacterial population density increases. Bacteria that quorum sense monitor the concentration in the signaling molecules as a measure of their cell density and coordinate the expression of genes that modulate activities that are advantageous when performed by groups of bacteria acting in synchrony. So again, bacteria are more powerful when they're acting together in a coordinated fashion, very much like humans, and political movements or anything that religious movements, etc. When people are acting as a group, there's a lot more power as opposed to a sole individual. Another visualization of what I call a swarm effect or quorum sensing. This is one of my favorite things to watch. If you've ever seen this, it's called flocking behavior. And this is a nice visualization of, you have a bunch of starlings here, and each one is an individual. However, they're acting in unison as a swarm, and it's visually stunning, and it's also very dramatically illustrates the effect of quorum sensing and swarming in organisms. Now, when patients have bad cases of Clostridium difficile, I'll get into treatments in just a little bit, but one of the most successful treatments for Clostridium difficile infections is stool transplants. I don't know if any of you have had any patients who've had this. I've had a couple of patients who have needed this. And in this particular paper, they talk about repopulating the gut. Both patients were infected with a hypervirulent C. difficile strain, ribotype 078, following stool substitute treatment. Each patient reverted to their normal bowel pattern within 2 to 3 days and remained symptom-free at 6 months. So there are some patients who have such significant dysbiosis in the gut and an overpopulation of C. diff and C. diff toxins that you're not able to really fix this with the traditional methods, which I'll talk about in some upcoming slides. So here you have sort of a visualization where you have perturbation of the microbiome with an antibiotic. You eliminate certain organisms, there's no repopulation of those organisms, and that causes a perturbation in the GI microbiome. And this really has to do with understanding that there is networked fashions in the microbiome where there are stability and a fragility of the microbiome. And in the same way that you can eliminate a single node in a network and the network can still be up, an example of this would be on the internet. If one service provider goes down, there's enough redundancy where it can still work properly. But if you take out enough of the critical nodes in a network, you can cause the whole system to collapse. And when that happens, the only way to sort of fix it, because there are so many nodes that are taken down, is to do fecal transplantation in cases of refractory C. diff. And this is just more of the same, looking at the various microbiome species as nodes in a network. And each of those particular bacterial species have different biochemical properties. Some will metabolize inulin, some will degrade mucus, some will produce butyrate, ferment various amino acids, etc. So this is very complex interactive biochemistry that's taking place when you have hundreds of different types of organisms in the GI tract. So the next couple of slides here are some papers which blew my mind when I read them. I thought they were really fascinating, and I included them in this talk as a better way to understand C. diff and also stool transplantation. So it's been known that transplantation of the microbiome, and this is studies done in mice populations, so you can actually implant microbiota from healthy mice, and this can actually prevent the development of liver inflammation and insulin resistance, indicators of liver disease and diabetes. So microbiota transplants can have a therapeutic role in the development of these diseases. Again, the microbiome actually acts as an organ in the body and has a very, very complex array of biochemical activities that it's doing. The next slide talks about how the microbiota transplantation in a patient with C. difficile infection, one of the mechanisms that it's doing to restore the normal balance or orthobiosis is it's affecting the fecal bile acids. This is an area that I think is really fascinating. And what they found is that strikingly, secondary bile acids, and remember, secondary bile acids are bile acids which are transformed by gut bacteria. In patients who had refractory C. diff, they were simply not detectable in any of the pre-fecal microbial transplant samples. This next slide sort of shows various families here, and you can see the listed organisms. I'm not going to go over all of them, but you can see that in certain cases, like the Enterobacteria acei, are very, very high in the pre-fecal microbial transplant patient with C. diff and almost non-existent in the donor. And then likewise, you can have very high levels of Bacteroides acei in the donors, but very, very low in the pre-fecal microbial transplant patient. And then in post-transplant, you see a transformation of those families. And this is looking at the phyla level. Again, marked differences in the phylums of donors versus the pre-microbial transplant stool analysis. and then in the post-transplant analysis. So what you're really doing is you're sort of rebooting the gut because of the host of the various organisms that are being transplanted in a fecal microbial transplant. Again, here's an evidence here of the high levels of fusobacteria and proteobacteria. And remember, these types of organisms are the pathobiomes, which are more the pathogenic type of bacteria. And also an interesting finding in this particular study was unclassified bacteria. There were high levels of bacteria which have yet to be classified in donor stool, but very low in the pre-fecal transplant patients. The proteobacteria include a wide variety of pathogens such as E. coli, Salmonella, Vibrio, Helicobacter, and Yersinia. And this is from a color standpoint showing what a donor relative abundance stool sample looks like. I'm not going to go over all the different colors, but you can see that there's a distinct color pattern or family, if you will. This is a healthy family, to take the Anna Karenina analogy. And then in the fecal microbial transplant, what you see is lots of red there. And those are high levels of the proteo or pathobiome bacteria. And in the post-transplant analysis, you see that those proteobacteria more or less disappear. And you see higher levels of the Bacteroides and Firmicutes in the post-transplant also. Again, another sort of looking at this from a color standpoint. And on this particular slide, the thing that I wanted to sort of emphasize is the down towards the bottom on the post-fecal microbial transplant is a large abundance of bacteria which are quote unquote unclassified. So in the process of doing a stool transplant, we are transferring a variety of sort of unclassified organisms which potentially have health benefits at restoring orthobiosis. This next slide is really interesting because this highlights the importance of these compounds which are called secondary bile acids. Now, to my knowledge, there's no clinical laboratory that's measuring them. I'm hoping that Diagnostic Solutions will be doing this. I'm trying to get them to look into this because I think it's really quite important not only for C. diff but for other components in the body. And what you see on the top are the primary bile acids. These are the bile acids that are produced by the liver, and on the bottom are the secondary bile acids, the deoxycholic acid, the lithocholic acid, and isodeoxycholic acid. And what you see here is that these secondary bile acids, again, these are produced by the action of bacteria on primary bile acids, are pretty much non-existent in patients with refractory C. diff. So that tells us that the action of bacteria on bile acids is critical for maintaining the balance of the microbiome. And you can see in the donor stool that there are high levels of these secondary bile acids, and also in the post-transplant patients, these secondary bile acids return to normal. And this is a nice visualization how antibiotics promote recurrence of C. diff by decreasing hydrolysis of the bile salts and conversion of the primary bile acids into this secondary bile acids. And this is really an important concept if we want to understand what's really happening inside the GI tract in these patients with refractory C. difficile infections. Interesting, another dysbiosis or dysfunctional family, and this has to do with a particular type of Clostridium species called Clostridium sinendens, is actually a beneficial Clostridial. And remember, not all Clostridial species are bad. Certain types of Clostridium, Clostridium botulinum, Clostridium difficile, Clostridium perfringens, can be bad actors, but there are Clostridial species which are actually quite good. One in particular comes to mind is Clostridium butyricum, which produces high levels of butyrate and is very beneficial for proper GI function. In this particular paper, they show that the organism C Scindens is also a member of the Clostridium 14A clade, has been shown to aid in the expansion of anti-inflammatory Treg cells via butyrate production. And butyrate is a primary cell for enterocytes that can resolve colitis, and loss of butyrate is also associated with Clostridium difficile infection. So having this particular organism, which helps with production of butyrate, protects against Clostridium difficile infections. So here you have another schematic where there's no antibiotics. There's adequate levels of the organism's C Scindens. You have transformation of the secondary bile salts by the species, and those secondary bile acids act as natural antibiotics and prevent quorum sensing and spore germination by Clostridium difficile. If you eliminate C Scindens with the use of broad spectrum antibiotics, you're not able to then produce secondary bile acids and also butyrate, and there's spore germination and there's overgrowth of Clostridium difficile, and there are the various consequences because of the dysbiosis thereof. Another important factor in C. difficile infection is that patients can actually present with C. difficile not with diarrhea. And this is an interesting clinical case taken from the British Medical Journal case reports from 2012, where a patient presented in the hospital with worsening shortness of breath, cough, and respiratory distress that slowly worsened over 7 to 10 days. The patient had had a viral-like illness with a cough and runny nose for about a week, and then started having productive yellowish sputum. She was treated with an antibiotic and steroid with clinical improvement. Leukocyte count continued to increase despite discontinuation of the antibiotic and steroids. All culture results returned negative. She did not have any abdominal pain or diarrhea. However, her stool was positive for Clostridium difficile toxin assay by PCR. So again, remember that not all patients with C. diff infections will actually have diarrhea. In some cases, they'll actually have presentation with constipation. And again, the learning points for this is that it usually presents with diarrhea, but absence of diarrhea does not exclude the diagnosis, especially in hospitalized patients. Severe Clostridium difficile infection may present without diarrhea when in the right colon or the cecum's involved, or there's a paralytic ileus. Now, always sort of remember this, because Clostridium botulinum paralyzes the gut, and in some cases, the C. diff toxin can actually do this. Severe C. diff is usually treated with IV metronidazole and oral vancomycin. Rectal vancomycin is also recommended when there's a complete ileus in C. difficile infections. This, I'm going to sort of have a little bit of an aside, but I still nonetheless found this sort of a mind-blowing concept of how beneficial the full microbiome is in helping restore balance in the GI tract. This is a serendipitous finding where a patient had refractory C. diff and also developed refractory celiac disease, and secondarily developed refractory C. diff infection. The refractory C. diff infection was treated with fecal microbial transplant. And interestingly, the patient showed full recovery of duodenal villi and disappearance of celiac symptoms. So this case suggests that altering the gut microbiota may hold promise in improving the clinical and histological consequences of celiac disease and/or refractory C. diff infection. So we've all been taught that celiac disease is just about avoiding gluten, but in this particular case, the patient had refractory celiac disease, and this is I don't know if any of you have seen this, but I have, and it's always puzzled me what's really going on there, because we're taught that if you remove all forms of gluten from a patient's diet, that they should regrow their villi, but in some cases that does not happen. And the mechanism for that is not yet classified number of organisms which are not present in the microbiota of patients who have refractory celiac disease and fecal transplant. And there's probably some unknown organisms that are unclassified organisms that are received during the transplant that allow the restoration of normal orthobiosis. And this is just showing, in this particular case, at the phylum level, there's the average donor, and the donor in this particular transplant was donor 28. And what we see here is a large number of the Bacteroides species, which may be one of the reasons why this patient did so well, because Bacteroides species are beneficial for helping with secondary bile acid formation. I'm going to bring up another example of the effects of fecal microbial transplant just for teaching purposes here. And I found this recent report really quite fascinating. This is taken from last year, May of 2017, how fecal stool transplant actually cured epilepsy. This sort of blew my mind when I read this. Here, to the best of our knowledge, we report the first case that fecal microbial transplant to achieve remission of intestinal and neurological symptoms in a girl with celiac disease and a 17-year history of epilepsy. During the 20 months of follow-up, fecal microbial transplant has proved its efficacy in preventing relapse of seizures after withdrawing anti-epileptic drugs. And this is a more recent paper on the role that the gut microbiota mediates as the anti-seizure effects in patients who are doing the ketogenic diet. And we all know that when a person has refractory seizures, going on a ketogenic diet has been shown to mitigate seizures or completely eliminate them. And we've always been taught that it's the ketones that do it. But what we're seeing here is that it's not just about the ketones. Enrichment of and notobiotic co-colonization with ketogenic diet-associated Akkermansia and Parabacteroides restores seizure protection. Transplantation of the ketogenic diet gut microbiota in treatment with the two organisms each confers seizure protection to a mice-fed control diet. Again, this was done in a mouse model, but nonetheless, this is probably applicable to patients. And what we see here is that there's alterations in the colonic, luminal, serum, and hippocampal metabolomic profiles that correlate with seizure protection, including reductions in systemic gamma-glutaminated amino acids and elevated hippocampal GABA and glutamate levels. So this is there's more to be said about the ketogenic diet just being butyrate or alpha hydroxybutyrate. It's also related to the shifting of the organisms. And the authors further state that we show herein that the gut microbiota is necessary and sufficient for seizure protection in 2 mouse models of intractable epilepsy. Again, this is a mouse model. It's not been shown in humans yet, but this is really nonetheless quite stunning. And this is again showing you that on various days from day 0, 4, 8, and 14, how you get larger increases in the 2 particular species, Akkermansia muciniphila and Parabacteroides, which confer protection against seizures in a mouse model. This is sort of just showing you the effects of the ketogenic diet being higher in fats, lower in carbs, alterations of the gut microbiota, changes in the colonic metabolome, which in turn affects the blood metabolome, and this is measured by decreases in gamma-glutamyl amino acids. This in turn affects brain metabolites with increase in GABA to glutamate content and protection against seizures. So really quite fascinating peripheral effects in ketogenic diet, with the effects being primarily from changes of various organisms by the change in dietary components. So there's changes in the gut microbiota are required for the anti-seizure effects. Specific ketogenic diet-associated bacteria mediate and confer this effect. and they also regulate hippocampal GABA and glutamate. Now, as far as primary and secondary prevention of C. diff infections, this is a nice paper, looks at a meta-analysis and systemic review. And if you're looking for clinical things to use for primary and secondary prevention, this is the paper to read. 4 different types of probiotics were found to be primarily effective for primary prevention, which was Saccharomyces boulardii, L. casei, DN 114001, the mixture of Lactobacillus acidophilus and bifidum, and the mixture of Lactobacillus acidophilus, lactocasei, and lactorhamnosus. 4 probiotics significantly improved primary C. diff prevention, and they're listed there. I'm not going to read them off. And then only 2 types of probiotics, S. boulardii, which I use quite a bit of in my practice, especially in patients with inflammatory bowel disease or in concomitant use of antibiotics, and also Lactobacillus rhamnosus. Those 2 together had sufficient numbers of trials to assess for secondary prevention of C. diff infections by meta-analysis. So those are things to take into consideration if you're trying to prevent both primary and secondary C. diff infections. One thing that I'll note is that when I used to work in the hospital and in nursing home populations, I got into gut microbiome research very early on in my career, and I always used to use probiotics in patients that I was giving antibiotics to. And fortunately, I was never had a patient who developed a C. diff infection from the use of antibiotics that I had given them, which is fortunate for me and them. The next paper is looking at more clinical pearls here, and which is the use of alternative and adjuvant pharmacologic strategies in the prevention and treatment of C. difficile infection. This is an excellent paper. You can find this on the internet. Just Google it in. These alternative strategies attempt to eliminate C. diff spores, replenish the normal gut flora, reduce C. diff toxin load in the bowel, and bolster the patient's own immune response to C. diff toxins. Metronidazole and vancomycin are the treatment of choice for mainstream initial therapy of C. diff infections for the past 25 years. But persistence of spores oftentimes leads to recurrence of infection in about almost a quarter of patients. And patients who have one recurrent episode have up to a 65% chance of having additional recurrences. And again, these are the patients who are more prone towards refractory C. diff infection, which really can only be treated by fecal microbial transplant. This particular chart here or table shows the various dose regimens of vancomycin along with the metronidazole, also the use of probiotics and also prebiotics, which are again the non-digestible oligosaccharides, things like fructooligosaccharides. They list fecal transplantation. Again, that's the gold standard for patients who have a refractory C. diff. And then there are other things which are done more in the hospital setting, which would be whole bowel irrigation with polyethylene glycol. One of the things that I've used with really good success is toxin binding agents. The one that is used a lot in mainstream medicine is cholestyramine. Now, if any of you have had treated patients who have mycotoxin, the use in CIRS or chronic inflammatory response syndromes, cholestyramine is the mainstay. So cholestyramine can also be used as a toxin binding agent, and this oftentimes can help dramatically. And I think it also, in addition to the toxin binding, it also binds the spores. And I've been able to have patients avoid the use of IV antibiotics, hospitalization, even stool transplant by the use of toxin binding agents. They don't list them here, but other things that potentially could be helpful. I don't think I've seen any good case studies on this, but I do use it a lot. Is the use of charcoal or activated charcoal, and then combining that with bentonite clay. And then lastly, this is just a quick analysis of the GI map test. For those of you who have used it, here you can see that on the first page, these are basically the pathogens which typically will cause foodborne diarrhea or traveler's diarrhea. And the nice listing here of the bacterial pathogens, including C difficile that produce toxin A and C difficile that produce toxin B. Again, this is measuring the presence of the organism that is capable of producing toxin A and the organism that's capable of producing toxin B. It doesn't mean that you're actually measuring the toxin itself, but the presence of these organisms means that they're sitting in the gut, and under the right circumstances, antibiotics, stress, etc., or through the process of quorum sensing, they can sort of overtake and start producing these toxins, which in turn can then clinically present as a C difficile infection. And then they also, in the GI map test, list various parasitic pathogens and viral pathogens, which can cause diarrhea. On the next page, there's listing of H. pylori with the various virulence factors, which can be very helpful in patients with gastritis or ulcers. And then there's the listing of the normal bacterial flora, and then a nice analysis of the firmicutes to bacteroides ratio. You ideally want that to be less than 1. Higher levels of that has been associated with obesity and diabetes. And then these are some of the major organisms which, when they're reaching critical levels, again, you notice that the GI map has the actual numbers here. This is because the technology that's used is quantitative PCR technology, and the thresholds there of normal, when they exceed that level, that is where the laboratory defines that as overgrowth of dysbiotic bacteria. And then there are a variety of different organisms that are listed there that are normally found in the GI tract, but they're usually at low levels. I always like to make the analogy of my patients, these are like weeds in a garden, and when they reach high levels, they can oftentimes be associated with autoimmunity. There's also a listing here of yeast fungi, specifically very commonly Candida albicans. And then viruses, occasionally you'll see the shedding of cytomegalovirus or Epstein-Barr virus. In fact, I had one patient who came in and had seen a GI specialist, and the patient actually had a cytomegalovirus inflammatory bowel disease, and was able to get that under control once we treated the CMV. And then on the next page here is the listing of various parasites and worms. And then at the last part of the section of the GI map is the intestinal health markers of digestion, with elastase telling you about pancreatic function, markers of fat malabsorption. Elevated markers of beta-glucuronidase have been associated with problems with enterohepatic recirculation of estrogen, and trying to lower that, usually through the use of things like calcium D-glucarate, is a way to address that. And then also the measurements of anti-gliadin IgA antibodies, which tell you that the patient's having a mucosal response to gluten. And then secretory IgA. I've been seeing a lot of patients who oftentimes have a very difficult to treat refractory GI symptoms, and it's oftentimes associated with low secretory IgA. And one of the things that can be used in treating that are things like colostrum derivatives, or what I call powdered mother's milk to some degree. And then lastly, two of the very important tests on a GI map test are the measurement of calprotectin. Again, this is a marker for inflammation. It's sort of like the gut C-reactive protein. And if this is elevated, you need to be thinking about inflammatory bowel disease. And I like to actually sequentially monitor this to help show resolution. I'll even do this when patients are actually relatively asymptomatic, because this is a very, very sensitive marker of mucosal inflammation. And then the add-on test of zonulin, which is a marker of increased intestinal permeability, can really be very, very helpful in diagnosing patients with quote unquote leaky gut. So I'm going to go ahead and stop there, and then we can open up for any questions or comments that people may have.
Thank you very much, Dr. LePine. That was fascinating information. Really good feedback. And we do have some questions, and I'm going to sum this up because we're basically at the hour mark. I will sum up the questions into basically a 3-part question for you.
Sure.
And it would be this. Do you recommend clinical intervention when someone is asymptomatic and they show up with C. difficile? That's part 1. What is the approach that you take as far as probiotics, spore-based versus traditional? And then the 3rd part would be, when would you consider someone a candidate for the fecal transplant?
Okay, so the first question is if you identify Clostridium difficile that is capable of producing toxin A or toxin B, if the patient is asymptomatic, meaning that they're not having diarrhea or mucus bloody diarrhea, I would not treat. However, what that is telling you is that the patient is highly susceptible for C. difficile infection perturbations if they were to enter the hospital, if they were to go to a nursing home, or if they were to take antibiotics. So in a case like that, what you need to do is let the patient know that, make sure that they're always prophylaxed with probiotics, and you can also make an argument of putting them on a combination of Saccharomyces boulardii and the other probiotics that were listed there for primary prevention of C. diff. So you're more or less heading this off at the pass. But you don't necessarily treat that if you just identify the organisms and they're asymptomatic.
All right. Well, that's basically it. And thank you, Dr. LePine, again for this information. And just to let everyone know, this will be posted on the website and will be available for you to review this in our resource library. And Dr. Todd, thank you so much for being with us.
Okay, I want to thank you, Jeff, and I want to thank everyone for attending. Hopefully, you learned some good clinical information, got a better conceptualization of Clostridium difficile as a sort of a stealth infection, and what you can do to help identify it with testing, like using the GI map, and then also preventing and also having knowledge about the other alternative therapies for treatment, including toxin binding treatments and fecal microbial transplants.
Okay. Thanks again.
All right, thank you. All right, everyone have a good day. Bye-bye.
Bye-bye.